and have experienced information will probably change as time goes on. So it's current as of today, and things do change. So I will demonstrate how good I am at technology here. Okay, so here is my PowerPoint present. So, thank you for having me. And so what I want to talk about today is the following. So how does one access testing? Is it free? Because I know that's a big concern, maybe not for you as individuals, but just in the national dialogue and in your communities, how much does it cost? This I'm going to take a little bit of time to go over, just talking about the differences, because I know that's a point of confusion, and I'm at risk of getting in the weeds here. And so if it becomes totally intolerable, please unmute yourself and just start yelling at me. And then what do we do with the results of testing? And Emily, to your point, how do you open up what makes sense? And kind of from a community health and public health perspective, I think this is really the question that we all are trying to figure out. So how does one access testing? So first and foremost, I would recommend, if you're interested in getting tested, if you have symptoms, reach out to your primary care doctor. More and more clinics are providing testing. There are limited screening opportunities through the health departments. As I think anybody who's in the Kansas City area knows, the Jackson County Health Department had 4 sites that they opened up pop up earlier this week, and all the appointments were booked within hours. So it's limited is really the key word here. I would caution to be aware and to be aware of the direct-to-consumer testing. These are the ones that are being marketed that you can buy and have done at home. A lot of them are unregulated. They're not really reliable. I will say the caveat is that both Quest Diagnostics and LabCorp have come out with validated testing. And those are 2 brands that I do trust, sort of as much as you can trust anybody during the current climate. But for the most part, the ones that are being marketed directly to people have some have a lot of drawbacks. And then lastly, those admitted to hospitals are getting priority for testing, and I think we can all agree that that's a good thing. So, is COVID-19 testing free? So the first thing I want to say, that nothing in life is free, kids. I think that's a really important thing to remember. And the better question really is, who's actually paying for COVID-19 testing? So when the Trump administration came out about a month ago and said COVID-19 testing is free, I think a lot of the public was dismayed because nobody could figure out where to access free testing. And so there's a nuanced answer to how much does it cost and is it free. So there's 2 different ways that doctors get paid. And Rhonda didn't mention, my business model is that I essentially have removed, at my little primary care practice here, we took the insurance intermediaries out of the equation because insurance has always been, in primary care at least, not the best partner to have to promote people's health and well-being. So I think about things a little bit differently when I think about the cost of healthcare. So anyway, 2 different ways that doctors get paid. So one of them is via claims processing. And that means that your doctor provides the service, but then asks somebody else to pay them after the fact. And so your insurance company, if you have an insurance plan that is purchased through the Affordable Care Act, the exchange, or through a large employer, your insurance company was mandated back on the 18th of March, the legislation that passed. The law specifically says that COVID testing has to be paid for by those insurers. And so if you have a policy like that, it is covered in full. Now, there's a lot of caveats regarding, is the visit covered in full? Or, if you don't get tested, but you have a visit, that gets a little nuanced. I'm not going to get in there. But essentially, your insurance company should be paying for COVID testing. Also, there was a carve out for those who are uninsured, whereby doctors' offices, via asking for payment after the fact, can ask for payment from the Health Resources and Services Administration, or HRSA, HRSA, for reimbursement to serve the underserved, which is pretty cool. Again, it means that the clinic itself has to step up and essentially pay for the test and ask for reimbursement later. And so that can be a huge strain on the infrastructure of the healthcare system in a time when we're seeing everybody struggle there, but it's still an option. And then who else pays for it? the public health system. So this is a lot of funding, or some funding has gone to like the local health departments. So that's where those tests are paid for. And then ultimately, a lot of people are having to pay out of pocket for it because clinics can't rely on this system. So they're actually charging the patient directly. And so it's kind of tough because, we're all in financial dire straits right now. And it's sort of like, well, who's going to pay for this test that's super important? The answer is could be one of many players, and it's complicated. What is the difference between the testing types? So there's so many differences. But to start, I'm going to just lay out that there are two essential tests that we're talking about today. Number one is this molecular or PCR testing, and that's done via a swab. And I know this is a small picture, but if you all have ever had this done, it is not a comfortable, two thumbs down. It's not the most pleasant thing. It's essentially a really long Q-tip that goes back to tickle the throat area. It doesn't feel comfortable. But that is essentially what we're talking about when we talk about the PCR and swab testing. You can actually do this exact same test by doing essentially the same mechanism as a neti pot. And so some people think that that actually is more tolerable. And so at least at our clinic, we offer both of them. But in the press, you're going to hear people talk about swabs and testing. And this is what they're talking about, is this one. Not to get in the weeds, but essentially the way that PCR works, it's a polymerase chain reaction. And from that little swab, through different thermochemical processes, it doubles and doubles and doubles and doubles and doubles the amount of DNA that's on, or that's in the sample. And in this ridiculously small part of the graphic, you'll see that eventually the test can detect a certain number of these particles that are present in the sample, and that's how you get a positive result. So that's PCR. The second type of testing is called serology, or antibody via IgG or IgM antibodies. And that's done either, as you can see here, with a little finger stick, or it can actually be done like a blood draw if you've ever had your cholesterol checked or something like that. It's a similar method. So this is a pretty cool technology, but they basically put your blood sample into a bunch of different chemicals, some of which have the little particle that replicates what COVID looks like. So it attracts that antibody to stick to that, because that's what antibodies do. And then it puts a subsequent little indicator antibody on top. And this is what we're looking for, is this little light up indicator. And so you're testing whether or not these indicators are attached onto an antibody that's attached onto essentially a decoy COVID particle that's within the chemicals. So those are your two different types. Now, to go through piece by piece, and I was actually interested that when I Googled, this wasn't quickly available online. So to go through just in a table format, you have the swab, the PCR, the first one I mentioned, and then you have that antibody or serology test, the antibody one. And here's the big difference, is that the goal of that one that goes in your nose is to diagnose people who are actually sick right now. They are infective, they have the virus, etc. The other one, and I think this has come across in the news pretty well, the goal is to find people who have previously had the infection, but potentially have either completely recovered, or that they're in the early stages or whatnot. It can, under certain circumstances, also be used to look at those who are actually currently infected. That gets a little bit into the microbiology that I don't want to bore you with. But essentially what we're looking at is the previous infections here. We talked about the two differences in how you get them. Obviously, when we talk about people being able to do testing at home, a nasal swab, theoretically, people can do at home. And LabCorp Diagnostics released actually a test that uses a nasal swab that people can do at home. The cost for that, I am not sure what it is quite yet. But in my mind, thinking about all the people who I've swabbed myself and how much people don't like to have that Q-tip put all the way back into their nose, I worry that, doing this at home isn't going to get us a very great sample, just because people, for very obvious reasons, don't like to put Q-tips way up in their nose. Also, kids listening at home, don't put things up your nose. There's your PSA for today. Anyway, and then this one is the blood draw or finger stick. And, ultimately, same question as far as home testing. This is a real possibility of doing finger sticks at home. And so that could be something that happens, as we move into the future. Not here yet, but that is a possibility. So what time frame do we want to do these in? So for that, the nasal swab with that polymerase chain reaction, the PCR, we can do it when people actually don't have symptoms, when they're asymptomatic. And you guys have heard about this, I'm sure, in the news, that people who are asymptomatic can actually have the virus. And that's being picked up by this test. And then we find that people are shedding the virus, that we can still detect it, sometimes up to 8 days past the resolution of people's symptoms. And this is a little concerning because, again, going to the whole, how do we know when people can go back to work and stuff? This was a really small study. I think it was 16 people that they did this study on. But they found that some of the people in that very small study were still, didn't have resolution of viral shedding until 8 days after their symptoms resolved. So keep that in mind. As far as the blood testing, it isn't going to become positive until about 5 days into symptoms. And this is that molecular weeds that I was talking about. The first antibody that's created anytime you're infected with anything is called an IgM antibody. And then eventually that IgM transitions into an IgG antibody. And that takes a little bit longer. You don't need to know the difference between, there will be no test, guys, don't worry. But essentially what you need to know, though, is that there's one test that shows essentially active and current infection, so people who are recently infected. And then there's another test that becomes positive much later. And these IgG antibodies are the ones that will stay positive, forever. They're the ones that your body remembers and that it continuously produces, so that, if in the future, theoretically, you are exposed to the same virus, that your body recognizes it quickly, mounts a response, and you don't become infected. We're going to talk about that a lot here in a second. As far as cost goes, if cash price, or essentially what your insurance price is paying the companies to do this, is going to be somewhere in the $50 to $119 range, just depending on which one you're doing. Quest is offering on their portal, which is kind of cool. You can sign yourself up to get the antibody testing, and just paying cash up front, they're charging $119 for that. Turnaround time. This is not helpful, I realize, but this is the truth. If you have the machine sitting right next to you, like for example, if you're in a hospital or something like that, you can get results in minutes. PCR does not take more than 45 minutes, sometimes a couple hours to do. However, if we're sending the swab or the sample off to a vendor and they have to ship it to California, and then you're in line behind hundreds of others, that's going to be days to weeks. And the same is true here for the antibody testing. If you have the machine sitting right next to you, you guys probably heard about this in the news, that there's a 15-minute test. Well, that's what they're talking about here, but it's only 15 minutes if you're standing right next to the machine. If you're sending your sample across the country, it's clearly not going to be a 15-minute test. And then here's the part that I'm going to talk to you about, because I don't mean to be a bummer here tonight, but it's my job to be a bummer sometimes. But we really do need to talk about the accuracy of these tests, because it makes a huge difference as to whether or not we feel comfortable about opening up or using testing as sort of a means to open up the country, if you will. I think a lot of the narrative has been, in order to open up, we need testing, we need contact tracing, we need more PPE, we need, da. And so let's talk about that little testing part, because that's what we're here to talk about today. So, oops, I hit the button way too fast. Oh my gosh. Let's go back. Guys, don't learn too much. Don't learn too much. Okay. So we're going to talk about sensitivity and specificity. So if you can imagine, and this is the weeds part, if you're super, super bored, please just walk away, go to the bathroom, get yourself a beverage, whatever makes sense. But in any population of people that we're looking to perform a test on, there's a group of people who actually have the test, who have the disease. They're positive. So in this example, we're going to, oh no. Oh, good. All right, good. All right, thanks, Rhonda. Huge vote of confidence there. So there's a group of people who have COVID, we'll say. So that's going to be this bump. Now, when you design a test, oops, excuse me, you have to pick a spot where these people are negative in the test world and these people are positive. So this line arbitrarily, we'll say, let's say this, this is a scale of, numbers will be 0 to 200 or something. Your test result comes back at 100, that's the cutoff. Those whose test result is less than 100 are negative. Those whose test results are over 200 are positive. So whenever you design a test, you have to pick a cutoff spot. You have to say, well, those to the right are going to be positive and those to the left are going to be negative. And in every single test you design ever, you end up with this little annoying section of the test where somebody has the disease, they have COVID, but because of where you set the cutoff, as I click, as I blah, 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 because of where you set the cutoff, you end up with what we call a false negative. And so this is a way to visualize what a false negative is that you've got this population of people who have the disease, but because we have to pick a number, you're going to have a false negative of a certain number of people. And so people look at this and they say, well, duh, move your orange line right here, right? Then you get rid of all of your false negatives. The problem with that is that at the same time that you have this population of people that has the COVID, you also have this population of people that actually doesn't have COVID. And they all are essentially on this side of your orange line. And so you have these two populations that exist. And you have to figure out where does it make sense to put this line so that you can minimize the number of false negatives, but also you want to minimize the number of false positives. Because if you have this group of people who don't actually have COVID and their little curve comes all the way down here, just by nature of how their body works, how they react to the test, how the test was collected, sampling errors, blah, 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 there are going to be people who don't have the test who are just on this edge of the bell curve. And so when you design any scientific test, it takes a lot of work to figure out where we put this line so that we don't create too many false positives or too many false negatives. Are we cool for a second? Does that make sense? Let me see, make sure that my chat isn't like totally terrible. Okay, good. Did it.
I'll watch that for you. Can I ask a quick
okay.
question then? So this, as we learn, does that line get finessed as we improve the particular test for this particular?
That's exactly right. If you can see my picture, essentially those two curves, we can pull them apart a little bit better as we can be more specific with what we're targeting in our testing.
And because we know antibody test help to inform the accuracy of this test? Am I skipping ahead?
You're no. This is exactly where this is going, is that these modalities start, okay, good. This means I'm actually making a little bit of sense.
Oh yeah, this is fascinating.
Okay. So one point, before we get to that point specifically, there's one more thing I want to say about this. So if you're a nerd, I guess, if you're an epidemiologist or a statistician, the concepts that I'm kind of explaining here are sensitivity and specificity. So you'll hear these thrown around. It's how labs decide how good their tests are and whatnot. And essentially what you're looking at when you look at these two terms is, how good are you at finding your true positives? How good are you at finding your true negatives? So that's these two terms. There's one small thing that's really important, is that sensitivity and specificity exist outside of reality. They exist in a world that is completely controlled on a lab bench. And they don't actually have a ton of meaningful use in the whole population, because in the real world, or whatever world we live in, this is actually more along the lines of what things look like. So particularly with COVID, for example, and in Kansas City, we have a ton more people who are negative, because we think the population rate is around 4% in the area, maybe, based on the testing that was done in Johnson County that they published last week. And so essentially, and this is not, again, I'm not a statistician or an epidemiologist, and this is a drawing that I made, so it's not to scale. Please don't take this and publish it in a research paper. But to illustrate the point, as your population has more negative people in it, just by sheer number, there are just simply more people that do not have COVID than there are people who have COVID. This area, just by sheer number, just gets bigger. So you end up with a lot of what we call false positives. And that's where the rubber hits the road with regard to that sensitivity and specificity and all that sort of lab mumbo jumbo. When we start talking about actual positive predictive value and negative predictive value, that's actually more important than those little lab jargon pieces that we went over in the previous slide. Because like any good scientist, all scientists want to talk about are things that are completely in their control. And specificity and sensitivity, you can design a little lab and you can figure out how good is my test. But once you take it out into the real world, those numbers get augmented by the fact that when you have a ton of people who actually don't have the disease, and we call that a low pretest probability, you end up having way more. When you get a positive, it tends to be more of a false positive than of a true positive. Again, my graph is not to scale. If I were to have made this actually to scale, my plus side would have been much smaller, so it would have been more dramatic. But this is problematic, because when we look at how do we figure out who's really positive, how do we figure out who's really negative, yada, 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 the lower the rate of infection is in a community, the higher the risk of a false positive. That's the take home point, is that because we have a low prevalence in Kansas City, we have a really high risk of getting a false positive when we do get a positive test. And that is true of both the PCR nasal swab testing and also of the antibody testing. So it's true of both. Okay, out of the weeds, we're done. That's all the science talk we're gonna have for now. Because, and this is where we're headed with this, and hopefully we haven't used up too much time. The big questions are, can we trust a positive result? Can we trust a negative result? And as time goes on, Rhonda, to your point, we will have more and more and more data to inform us where to draw that line, where we can reduce the risk of both, false positives and false negatives, and we can trust our testing a lot more as we do more of it. And so it's just a matter of sort of learning to walk before you run. It's the hard knocks of science. We just need to do more and more and more of it so we can learn more and actually come up with better numbers. This is what you hear about a lot, I think, right now in the news, is the antibody testing. So far, all of the antibody testing are authorized under this emergency use authority. And so they haven't gone through the rigorous FDA approval process, which is good because it means that they came out fast. It's not good because it means that doctors like myself, we're used to outsourcing the need to verify testing to the FDA, to lab vendors, to people like that. Like, I can't be an expert at making sure a lab test is valid. I trust my other experts to do that. And so we're kind of on this hyper speed where people are developing things quickly and sort of checking later to make sure that they're accurate and that they work well, for better or worse. So it's sort of like, you can pick speed, which means you're gonna have less regulation. And so the administration was heavily criticized for picking regulation at the beginning, which meant that when tests were released, the PCR testing, that it was a really good test after a little bit of a hiccup from the CDC. So now we're in sort of the other side of the pendulum. So for what it's worth, it's a little tough to figure out the validity of these antibody tests. And because they haven't been validated, ironically, every single one of the tests that you can get right now in the market specifically says that you should not use them as the only means of verifying an infection. So you're doing this test because ostensibly you want to know if somebody's infected, and the exact testing material says, well, don't use this as a means to figure out if somebody's infected. Like, head exploding emoji. I don't know what to do with this. Like, it's crazy. Okay, so moving aside, like, can we trust the tests? Let's say we could trust the tests. Let's say they were 100%, you only got a true positive, or you only got a true negative. They were the most perfect test, which, by the way, doesn't exist, but whatever. They're a perfect test. Does the fact that somebody has those antibodies, does that mean that they're actually immune? And we don't know the answer to that either, because we just don't have enough time with this virus to know that if I have been infected with COVID and my body mounts that IgG response that I talked about, that antibody response, and I keep my IgG and my body remembers it, and it's surveilling and always looking for more COVID to attack, will that actually give me protection? And we don't know the answer to that. And so, Rhonda, you already guessed my big thesis, but my guess is that we will eventually use a stepwise algorithm for diagnosis. So a PCR followed by an antibody, or vice versa, an antibody followed by a PCR. Sometimes, and if anybody has had to do this with like tuberculosis screening and testing, we have a screening test for tuberculosis. And if it's positive, the gold standard that we actually look to see if somebody has TB is that we actually do a chest x-ray. And so it's not uncommon to think, well, we do a lab test followed by an imaging test. So let's say your lab test says you might have COVID, well, then maybe we do an x-ray after that to see, like, do you have lung inflammation? And so it's, I mean, that is up, and this is not, by the way, not a published thing where I think we should do this, but rather, I think that eventually we're going to come to a sort of sequential algorithm as to figure out, number one, who's infected, number two, what can we do with immunity? So, or excuse me, what we can do with the antibody testing. And then my last point, and this is the very last thing I have, is that regarding the question of does past infection equal immunity, the only way we will be able to figure this out is by giving it time. And that is incredibly painful, and it's we're going to have to decide as a society what we want to do with that, because immunity will wane, sometimes wanes over time. This is why we get a tetanus vaccine every 10 years, is because your immunity to that vaccine will wane with time. We know that, like, what else was, pertussis, the whooping cough, same thing. We've seen that people need boosters of that. So immunity needs to be assessed over time, and it's, how much time do we have, what decisions do we need to make, blah blah blah. So with that is, I think, my last one. And so I have no advice. I don't know what to do, Emily, with opening up the art museum. Good luck. Maybe just have everybody wear a mask, and they shouldn't touch their face, and they should wash their hands.
I love that. Thank you. Thanks for everything. Can I just interject with a short question about the antibody testing?
Go for it.
Knowing that you, of course, cannot endorse or suggest any sort of particular testing, are there others like the New England Journal of Medicine or other really great sources or reviews you would suggest that are looking at the various companies that are producing this antibody testing and are kind of looking at the success rates, looking at their backgrounds as a company and their sort of entry into this antibody market?
Great question. The way that I'm taking this in as a physician is that I am using the lay press, like the news, to give me the high level trends, because all of these companies will send out big press releases that generally are covered in the national news. And so that is how I get my little nuggets of information. And when I hear about those, I then go to the vendor's website to actually read their press release, which is always a glamorous, there's nothing wrong with us, everything is perfect type thing. And then from there to take it into those research articles like JAMA, New England Journal of Medicine, The Lancet, the British Medical Journal, all those are excellent resources. Only trouble is, this kind of goes back to my comment about the FDA, is that because they're peer reviewed, you need time to actually peer review them. And so all of those publications are a couple of weeks, which sounds so fast in research. Actually, a couple of weeks turnaround is super fast in research, but because they're a couple of weeks behind, it's hard to know exactly. It's like getting yesterday's news. I think that makes sense a little bit, but that's the way I'm approaching it. I wouldn't necessarily trust, I sound like a conspiracy theory. I wouldn't trust the media to be the exact best source of information, because as we all know, the 24-hour news cycle, people have to come up with stories. And so they kind of grab onto shiny, new, yada, yada, yada. And it's not necessarily, it doesn't always bear out, I guess is the way I'm saying it. So just use it as your high level, maybe I should look into this, and then follow it up by, if it's intriguing, follow it up with a little bit more validated resources. think is the way.
I think that's extremely prudent, actually. That doesn't sound conspiracy-like at all, and Erin agrees. And I think that that's one of the reasons we wanted to do this, so we can just get some straight talk, even though we know there's not exact answers, but we need some straight talk and just some reasonable thinking from someone who's in it. Yeah. Questions? Anybody else have questions for Dr. Edwards? Susan?
I don't know. This is tell you why I'm a librarian and not a doctor. If you're doing the swabs and you're trying to get to the back of the throat, why are you going through the nose to get to the back of the throat and not the mouth? Not that it's going to be any better, but
I don't think I've ever pondered this because I'm so indoctrinated. I'm like, of course you go through the nose. But essentially, your nasal mucosa is your mouth has a lot of crud in it. Your mouth is a dirty place. It's got a lot more going on in it.
yeah.
Just yours, Susan. Just yours.
Sorry, got to call you out.
See that?
Yeah. But essentially, if you're going through the nasal cavity, you're getting the mucosal secretions in a decently pure form, as opposed to the secretions in your mouth, which are going to have. This is what you guys all wanted to talk about, right? It's secretions, nasal secretions.
Our world.
But that's what you're going for, because the RNA, the virus replicates within that junk. And so you're getting better junk in your nose than you're getting in your throat, even though it does eventually go back and kind of they intermingle.
Okay, that makes sense.
Yeah.
Thanks, Susan. John? You're muted.
Follow up to that, is the spot that you're trying to test from above the velum? Is that part of why you can't go from the throat? Like, is it still in that upper throat area, or is it below the velum?
So you don't have the gag reflex as much is the other part of it. You can swab the throat, to your point. You can actually do the testing that way. The very limited studies that have come out of the Wuhan province and some of the Chinese studies have just shown that you get more false negatives if you go just oral. So it's just a better sample. But yeah, the gagging is also part of it. Nobody likes the back of their throat being swabbed. But nobody likes their nose being swabbed either. I don't know. I said that's the alternative, but yeah, nobody likes that.
I think administering that test at home would be extremely difficult to accomplish. Yeah.
And on that point, so you'll read some of those tests, but cut me off if we're going long or whatever. But those tests, they'll say they're 99% accurate, which is true. In a lab, in a controlled setting, they are absolutely amazing. But you have to do the sample collection correctly, and you have to get the right goober essentially to make them 99% effective. It's true.
Thanks, right. Even the Gills kids understood that one. Go ahead, John.
Different question. When you talked about the whether or not immunity will last, what are some different factors that can lead to something, being able to keep immunity for longer or not once you've had the disease?
Yeah, no, a hugely important thing. And when I speak to this, I'm going to speak generally from like vaccines in general, because that's where a lot of our immunity studies come from, as opposed to speaking specifically about COVID-19. But immunity comes from a couple different things. So number one, if you didn't have a very robust infection, not exactly sure how that's defined, but let's say you just had a mild infection or something like that, and your body doesn't really respond in a vigorous way, potentially that's where you could have sort of a decreased in immunity. So that's one way. Another way is that if you are immunosuppressed, quite literally, you are suppressing your immune system. So if you are, for example, you get infected and perhaps you're on steroids or you're on something like Humira or another immunologic that suppresses your immune system, you could potentially not mount a very vigorous response. We know that part of if your kids have gotten vaccines, they sort of get a fever potentially afterwards. And we've actually found that giving Tylenol during that fever period creates a lower inflammatory response, because that whole reaction is exactly what we're trying to generate with a vaccine. And so having that inflammatory response is part of building immunity. And then the last part, or at least the last one that comes to mind, top of mind, is that we all know that a flu vaccine comes out every year, and every year it's the whole, will it work, will it not? And that's because the flu virus itself it's sort of like it switches out coats on a frequent basis. And so we design our vaccine to fit, to recognize one coat. Well, if it flip-flops and uses a completely different coat next year, our vaccine doesn't work. And also our immunity doesn't carry over from year to year to year to year, because our immune system is designed to recognize that shape, that figure, that coat. And if it changes, we just can't recognize it. And so those are all the variables at play. And not only that, but with regard to, so switching to specifically COVID, the assays that we have right now are not superb at saying this antibody is specific to the COVID, SARS virus to COVID, to this specific coronavirus, as opposed to the one that causes the common cold. We've all had coronaviruses before. Like it's what causes the common cold. And so delineating that explicit antibody, as far as testing is concerned, is also part of the problem. So yeah, that's enough for now. I'll stop talking about immunity.
No, that's really good stuff. I have a very practical question. I think you did answer it, but I just want to touch back to this. So being someone who, in the words of I won't say who, has a vector in my house who came from a hotspot in Europe, whose roommate was symptomatic and then when got home tested positive, and then as someone who had symptoms but doesn't know. And so we're hearing these things about you can get an antibody test, possibly donate plasma to help inform. How does one get in line for that? Should they want to?
So the first step would be to do one of the antibody tests, even with all of its negativity. We can still take a positive and figure out what to do with it next, whether it's confirmatory testing or yada yada. It depends on symptoms, it depends on time frame, all those things. As far as plasma donation, one of my colleagues in New York said that she was having trouble connecting people to donation centers. And in my mind, I was like, well, this is a New York problem that I don't have to solve right now. So I don't even know what the accessibility would be here, like in the metro, for example. So
yeah, we're even there yet.
Right. So big, I don't know. My thought would be my thought is that it's probably tied up in a research trial, which is probably coordinated through NIH. And that's where I would start looking, would be to see if there's a trial registered to NIH using convalescent plasma for COVID survivors. But I haven't looked into it, so I don't know.
I know this is Emily here, just jumping in a little bit. I know at least in the Chicago region, it's tied to the American Red Cross. So like during your normal blood donation and things like that, there are seeking plasma donations from recovered COVID patients.
Do you know, is it confirmed? Like, do they have to have proof of infection?
Yeah, I'm actually looking on their website right now because I was curious about that. And it does say, just at basic level, they say have prior verified diagnosis of COVID, but are now symptom-free and fully recovered. So
interesting. So that's even different from just not having it verified. Well, would the antibody test be a verification?
Yeah. It
so
would.
Many questions, but it's interesting to be a part of the thinking though, and just because I think everyone is overwhelmed and inundated by the questions. So just to partake in the conversation, I don't know, it helps my brain. And boy, the whole Edwards family is quite resourceful. Thank you. Got that. That's awesome. Yeah, Anne, go ahead.
Well, so I think it's just fascinating historically to imagine 20, 30 years down the road when our generation has children and we can say, let's talk about the time when our country had the COVID, kind of like when you hear grandparents talk about the Depression, when we have the COVID. And, you're right. We're in scary times, but also exciting times, because there's so many people making such a difference right now
Mhm.
that those stories will go on forever and ever, which is really exciting.
Yeah, yeah. I remember my kids were like, "So we're living history right now, aren't we?" And I was like, "That's exactly what's happening." And history is full of bads and goods and all of those things. Um, Fascinating. Excellent. Other questions while we still have a few minutes? Yeah, go ahead, Erin. I feel like a teacher again.
And you might still be muted.
Oh, no, you're good. Oh, that wasn't you. Yeah, you're muted.
Okay, how about now?
Yeah.
Okay. Um, so you've talked about what types of testing are available and how to access some of that testing. When is it prudent to seek out that testing? Like, assuming you're not hospitalized, and of course, then you're getting tested. Is there a reason to self-elect to get that, or just if you've got symptoms, wait it out, and don't get tested? Why would you choose to do that?
Super good question. So a lot of public health officials are wanting to now just test anybody regardless, simply to figure out, as we're hearing in the news, like who's out there asymptomatic with actual COVID. So some public health officials are actually saying, whoever wants to get tested whenever, just go get tested, which is a crazy thought to think about, because it involves actually having to access a healthcare setting, which then puts you at risk of actually contracting it. So, to each his own. As far as what I would say, just from a clinical perspective, like what I'm saying to my patients is that if you have any concerning symptoms, so fever, cough, chills, shaking, shortness of breath, even diarrhea actually is being linked to this, loss of smell or taste. I think those are the most of those. Like, those are all reasons to get tested. Ideally, with that nasal swab one, we want you to be tested while you're symptomatic, and probably within the first couple of days of being symptomatic would be ideal, because you're going to have the most viral shedding at that point. Although, like I mentioned, there are case studies where people shed it for days after having their symptoms resolve. So my sort of quick and dirty answer is I would do it if you have symptoms that are concerning. Albeit, if you have an exposure to somebody who does have COVID, like, then my recommendation would probably be a little bit stronger to, perhaps asymptomatic testing, et cetera, or waiting and watching and seeing, how things go. Because the truth is that we don't have a good treatment for it. And so if you're doing okay in a home setting, there's a lot to be said for just kind of powering through in a home setting. It's not very satisfying, but that's unfortunately where we're at.
When do you know, because it seems like for some, it could turn rather quickly. When do you know you need to maybe access medical assistance? What are those key, just the real strong shortness of breath, or you just kind of go with your gut? Is there some?
Yes, everything, all that. So ideally you have a relationship with a primary care doctor, because then you can ask those questions to somebody who knows you, knows your health history, knows the context, knows you as a person and as a physical being and all that.
Yeah.
So that's in the ideal world. Not everybody has access to primary care, and that's not ideal, but it is how it is. From a healthcare standpoint, and Emily, this goes back to where do you get your information? Doctors some of my colleagues who work in the ERs in New York are saying that it's almost like it's and this is not published, this is not peer reviewed, this is just people observing, that it's almost like a two-phase illness, where in the phase one, what we have is just that the robust immune response creates kind of leakiness in the lung tissues, where people actually can feel fine until they don't feel fine. And at that point, then we're seeing people who are being admitted to the hospital and are getting help with their breathing. And so some of my colleagues have said, well, if we can decrease the inflammation in the lungs by simply providing oxygen, for example, which is what the lungs are thirsty for, we can hopefully prevent the sort of next phase of that illness, where people really jump off the cliff, so to speak. Sorry, bad example. But that's an interesting theory. Granted, where do you access oxygen? Well, there are a limited number of home vendors. This is not, we don't have it piped into our clinic. Hospitals have it. And so, at this point, we're saying access care when you are at the point where, so first of all, talk to your primary care doctor, be in touch with them. But, shortness of breath is never normal. And shortness of breath, I demonstrate this for my patients. When I say shortness of breath, I mean like you have it's like you're almost running while you're talking because you're having a hard time finishing sentence without taking another breath. And like, that's shortness of breath. It's not that you're sitting or you're walking to the bathroom and you're like, man, I feel like I need to sigh right now, or like I need to take a deep breath. That's still, a disconcerting feeling, but it's more of I can't walk to my bathroom, or I can't have a conversation without needing to take breaths, if that makes sense.
It does. Thank you. Thank you.
Sorry, that was long and rambling.
No, it was good stuff. I think all of us we're here because we're fascinated by this. Any other questions? I want to be respectful of everyone's time, and we're right at 7:30.
My husband is making me dinner, so this is very nice.
Very nice. Well, excellent. I like that even better.
Yeah.
Well, seeing no questions, it was very nice to meet some new folks. It was nice to have a small, intimate group. Thank you so much, Dr. Edwards, for your time, your expertise, and really importantly, your passion. Because I think that's what really helps to get the information across in a very in bite-sized ways that are attainable for us lay people. So thank you for that.